All right, well, thank you. My name is Stephanie Weiss, and I want to welcome you to the session on CNS, and I want to thank ACRO for inviting us, and we've got some great speakers for you who are going to talk with you today about some areas that are evolving in the management of primary brain tumors. So we have Dr. Skip Grossman from Johns Hopkins. He's going to talk with you about treating elderly patients with high-grade glioma, and go over the literature and where we stand now, and how we think about this and how we treat patients. We have Manesh Mehta. He's going to talk with you about low-grade glioma and high-risk low-grade. Again, something that in the last couple of years has really evolved. And Helen Shih from Mass General will talk with you about low-grade glioma, low risk. And as you'll see, how exactly we divide along that plane, what constitutes high risk from low risk is something else that's evolving. And that's part of what makes it difficult, but it's also part of what makes it fun. The way we're going to do this is we're going to talk with you about a kind of a representative case that may have some debatable features. Just sort of take a hand-raising poll, see how you would approach it. We'll talk about this sort of back and forth like a tumor board, and then see what you all think again. Also, this is going to be a SAM session, so we're going to try and throw in some things that I think are going to be particularly high yield and give you some benefit. So we'll start with Dr. Stuart Grossman from Johns Hopkins.
So thank you very much. It's a pleasure to be here. I'd like to start with a case and then ask for your help about how to treat this patient. So this is a 73-year-old who is actually in remarkably good health, has a past history of type 2 diabetes, some prostate issues, and is a smoker. He had no symptoms until 4 days before prior presentation, when he had a little bit of left-sided weakness and then had a generalized seizure, ended up in an emergency room. Was found to have a right-sided mass in the brain that crossed the corpus callosum. He was placed on steroids and anticonvulsants. He underwent surgery, and the surgery came back as a glioblastoma, IDH wild type, and MGMT methylated. And what we're going to ask you guys to do is to help us figure out how we should treat him at this point in time. And our options, the slide changer is which one?
Right there, that's green.
Oh, okay, thanks. So you have several options. Number one, you can decide to give him temozolomide alone, given that he's an older gentleman, and see whether the temozolomide works. Number two, you can give him radiation alone, and you have the option to do that in either a 3-week or a 6-week session. Number three, you could give him radiation with concurrent temozolomide, and you can follow the recent paper that was published in the New England Journal, and we're going to discuss that. Or you could decide to give standard treatment as per the STOOP study in 2005, 6 weeks of radiation followed by 6 months of temozolomide. So I'll just ask hands for option number one. How many people would do the chemotherapy alone? How many people would do the radiation alone? How many people would do 3 weeks of radiation with temozolomide? And how many of you would do 6 weeks of radiation with temozolomide? So maybe we're split half and half between the last two, and we will take a little poll when we're done and see where we are. So the goal here today is to talk a little bit about the role of temozolomide in glioblastoma, but it appears that you guys are right on target with that. We'll think a little bit about this age 65 and over and where the cutoff should be, talk a little bit about comparing older and younger patients with glioblastoma, and then think about a standard of care and some takeaway messages. So if this gentleman had presented in 2004, then he would be along this survival curve here, with a median survival of less than a year and a chance of surviving more than 2 years, which is extremely small. As you're aware, The treatment of these tumors is very difficult. This tumor is not circumscribed, so a complete surgical resection is impossible. The radiation is limited by dose to the normal brain. Chemotherapy is limited by penetration of systemically administered agents into the brain. And we have a hard time with imaging because we're actually not doing a tumor imaging when we do an MRI of the brain. This is a blood-brain barrier dysfunction scan. The contrast enhancement is where the barrier is disrupted and where the dye gets in, but it's not measuring the edges of the tumor. In 2005, treatment changed because of this paper that was published in the New England Journal. This was a study of about 600 patients with newly diagnosed glioblastomas. They restricted the age entry in the study to be patients under the age of 70. Half of the patients were randomized to get 6 weeks of radiation. The other half got 6 weeks of radiation, but in addition, they got temozolomide given about an hour before the radiation every day and on the weekends, a month break, and then 5 days of temozolomide consecutively every month for 6 months. Their goal was to come up with a target of 16 months with a baseline of 12. They never made the target. They got 14 and a half months. But what really made a difference was not the median survival, but the survival at 2 years, which went from 10% to 26%, convincing all of us that that was worthwhile. So why think about doing anything differently in the elderly? So again, even with the best surgery, radiation, and chemotherapy, unfortunately, we cure nobody with a glioblastoma, regardless of age. In the elderly patients, there is very solid data that age is a very strong prognostic factor. These are patients 18 to 30. These are patients over the age of 50 in a large series of patients. And in addition to having shorter survival, these patients don't tolerate treatments quite as well as younger patients. So the solution is to make the course of treatment shorter, to make it less intense, to make it more convenient. And when you're doing that, you're willing to take some long-term neurotoxicity risks with a higher fractional dose because these patients have a pretty short survival. So all of this became easier because the ROA study published in 2004 compared 40 gray versus 60 gray and didn't find much of a difference. So the feeling was that you could do a trial like this in older patients. So let's look at the studies that have been published since 2005 for elderly patients and just think them through a little bit. So let's start with the STOOP study. It turns out that this study had 170 people enrolled in the study who were between the ages of 60 and 70. So again, you'll see that that's not far off from the elderly study where the median ages are in the low 70s. And you can see that the overall survival was actually better in the patients who got the median survival in the patients who got the radiation alone versus the radiation with temozolomide. But I'll show you data in a minute to show you that, in fact, if you look not at the medians, which, again, if you remember, that study didn't hit his goal, but at the longer-term survivors, the patients alive at 2 and 5 years were the patients who got the temozolomide. The Nordic study was published in 2012, 342 patients, radiation alone, but you'll notice that the median survival is very different than the STOOP study with radiation alone, lower dose of radiation, and now temozolomide alone, which didn't look very inferior to the radiation alone in that study. Again, the median age, these patients were ranged from 60 to the 80s. The NOAA 8 study, again, almost 400 patients, temozolomide alone versus radiation alone. And again, the survival figures are right there. And then the Perry study, which we're going to talk more about in a minute, which used 40 gray given over 3 weeks, and the same radiation 3 weeks with temozolomide. And there were 280 patients in each arm. These are the survival figures, median survival, about median age of the patients, about 82. So let's start by just reminding ourselves of the data that we have in the 60 to 70-year-old patients on the STOOP study. So if you take a look at the patients who were under the age of 50, sort of the best risk patients, and you look at the hazard ratios with radiotherapy alone or the radiation and temozolomide, about 0.6. If you look at the median survival, it's better in the combined. If you compare the 2-year survival with the combined versus the radiation alone, it's more than 2 times better, and you can see that that advantage spreads out over time. In the elderly patient, in this group, 60 to 70-year-olds, the hazard ratio, instead of being 0.6, is 0.7. Median survivals are not that different. But if you take a look at how much better the patients did if they got the radiation and chemotherapy, it's quite striking, suggesting that there's not much difference in the response of the people under 50 or the patients over 60. So if you take a look at the Perry study, again, this is the STOOP study, 6 weeks of concurrent radiation temozolomide, followed by 6 months of adjuvant, and the Perry dropped this down to 3 weeks of radiation. And the thing that you guys need to remember is that if you decide to treat a patient with 3 weeks of radiation, you are functionally making the decision for the medical oncologist that they're going to give 3 weeks of concurrent temozolomide. So they got 3 weeks of that compared to radiation alone, and then they were allowed to do 6 months or even a year's worth of treatment. So there are real differences between these two treatments. And they concluded that hypofractionated radiation with concurrent adjuvant temozolomide is superior to the same radiation without temozolomide. In other words, temozolomide adds something to radiation, which is actually not really new news. So we kind of knew that with the STOOP study. They did show that, in fact, you could do this safely without major impact on quality of life and with a reduction in the number of visits and so forth. But let's take a look at the actual data from these two studies. So here's the survival curves for the STOOP study, less than 70 years old. Here are the survival curves for the Perry study, greater than 65 years old, but a median of 72 years. Again, the median is somewhat different, and the 2-year is different from about 3% to about 10%. In the MDMP methylated patients, this is the STOOP data. This is the Perry data. Those curves look pretty similar. And in the unmethylated patients, again, you don't get very much bang for your temozolomide buck with those. Another way to look at the data is the blue square lines are the radiation alone, and this is with temozolomide in the STOOP study, and these are in the Perry study, the elderly. So even though the survivals are less as you get older, your relative benefit is not that much different with you get in the methylated and unmethylated, showing that temozolomide is clearly beneficial, primarily in the MGMT methylated patients, and the relative benefits are similar. So is a 65-year-old, or in this case, the patient we chose was a 73-year-old, is that patient a subgroup? In other words, are we defining a 3-week treatment regimen that should be for everybody over the age of 65? So the median age for diagnosis for glioblastoma is 64. So if you're doing that, you're basically saying, then I'm going to change treatment in everybody who's over that. That would be 50% of the population. It's not really a subgroup. It's a fundamental change, because in addition to that, you're probably going to recommend that treatment to people who are younger but functionally not doing so well. So again, we shouldn't think about this as a subgroup. This may turn out to be a very high percentage of our patients. Should we consider a 65-year-old elderly? So if you take a look at where that definition comes from, it came from Teddy Roosevelt in 1935, And it turns out that in 1935, that was the median age of death at that point in time and where Social Security benefits were given. If you go to Wikipedia now, a good medical journal, and you ask what is elderly, this is what it's going to tell you, that elderly is nearing or surpassing the average lifespan, which in the United States these days is not 65, it's 80. So I'm not sure that our 73-year-old should be called elderly. So the question is, should our 3-week regimen be considered standard for all patients with GBM? I think all of us would agree that in the poor prognosis patients, maybe they don't get Temodar at all, maybe they don't get radiation at all, but in the patients who do need treatment, who might be on the worse end of the spectrum, shorter course might make a lot of sense, fewer visits, less time, similar efficacy perhaps, and we understand we might be taking the risks with long-range consequences. But in our better prognosis patients, I think we need to think this through a little more carefully. For example, in the MGMT methylated patients, if you go to the Stoop data and say, if you've got an MGMT methylated glioblastoma, are you going to have long-term survivors? The answer is yes. Almost a quarter of the patients may live out 4 years. We have a considerable number of 5-year survivals who all of us follow. And again, I think we have to be cognizant of the fact that we don't have data about the neurotoxicity long-term with the hypofractionated. In addition, it is quite possible that we are impairing efficacy if we take the MGMT methylated patients where the concurrent radiation and temozolomide is probably the most potent part of the treatment regimen, not the adjuvant temozolomide, and we decide that we're going to arbitrarily cut that in half without any data. I think the controversy that all of this is brought up is the fault of us who are in the neuro-oncology field. And we haven't done a very good job of defining what are the critical components of therapy. So let's think about it. What's the best radiation dose and schedule? Well, standard versus peri, we're sort of saying might just be equal, but we have no data about that. And when you drop this radiation, you're dropping this temozolomide. We don't know what the optimal dose of concurrent radiation and temozolomide is. And in fact, we don't know that the adjuvant temozolomide adds anything to the concurrent. So it's on us that we haven't actually answered these important questions. So in terms of take-home messages, I think the real problem is that the Perry study and all of those other studies I listed never compared their treatment against standard radiation and temozolomide. So the Perry study compared radiation and temozolomide against radiation, but they didn't compare it against the standard radiation and temozolomide. There's a 50% reduction in the radiation fractions, a 50% reduction in concurrent therapy, concerns about late neurotoxicity, and quite frankly, I think there needs to be another study that compares the peri-optimal treatment with the Stoop optimal treatment so we have a good idea of what to do. For me, the gold standard of treatment is the Stoop paper until we have more data. I think the other thing this brings up is the importance of MGMT methylation. I know when we send the MGMT methylations out, it often takes at Hopkins 2 or 3 weeks for us to get answers back, and you guys have done your treatment planning before then. But this gentleman is 73. He was perfectly functional before. He presented with a seizure. He has nothing to get in his way. He could be one of those longer-term survivors. If you had his methylation status available, I think you might plan him differently. In addition, I think when we look at these studies, we shouldn't get caught up with median survival. They don't change very much. We're really looking at the tail of the curve. I've already mentioned the fact I think we need to determine the critical portions of the regimen. And I'd like to end by just, again, voicing some caution about defining elderly trials. Age is probably not the right way to do it. And the risk of undertreatment or late toxicities is real. And I think if we're going to present elderly trials, we should probably think Wikipedia rather than Roosevelt. So back to our case. 73, 4 days of weakness, generalized seizure, doing fine afterwards. Let's take votes again. Temozolomide alone, I don't think any of us are going to choose. Radiation alone, I don't think any of us are going to choose. 3 weeks versus 6 weeks. How many are going for 3 weeks in this gentleman? Raise your hand. How many are going to go for 6 weeks? So I think we have we could have some fun with this. So I'm glad to stop and be glad to take any questions that you have. Thank you.
So let me ask, I'm curious, Dinesh, what do you think of that? Do you feel persuaded we should be leaning toward 6 weeks for this gentleman?
I think Skip has made a very strong case for understanding that the 6-week course of therapy is where most of the action is, the radiation and the concurrent temozolomide. And arbitrarily cutting that by 50% in someone whose top line is very good health is something I would be very concerned about. So absolutely, I do use hypofractionated schedules, but it's in select patients that are not in very good health. So I use that much more often than I use age alone. So I blend age and performance status, age and other comorbidities to select the patients whose performance status and comorbidities are such that a short course is appropriate from a functional matching perspective. So I'm convinced that today, 6 weeks remains the standard for those who can tolerate it and are in good shape.
So, I was wondering how that worked. Go ahead.
Since the methylation information is important, can you imagine something that we can, so that we could get the methylation information before a final treatment plan is made?
So this is very frustrating for all of us. On the medical oncology side, which is where I come from, we have protocols now that are for patients who are methylated and other protocols for patients who are unmethylated. So we can't even talk to patients about which protocol they might be eligible for until that comes back. One of the problems that I think many of us have in our pathology departments is that there's a frozen section that comes, and then the pathologists want to sit down and formally read it, and once they formally read it, then they feel like they are justified to send off the MGMT, and the MGMT is usually not done in-house. It's sent out and it takes 2 weeks to come back. I think what we're trying to do at our institution is convince them that if the frozen section says high grade, they should send the MG, because then 2 weeks later we'd have the answer and we'd all know what to do properly. So I would go to your pathology department, I'd argue with them.
Dr. Welsh?
Can you hear me?
Yep.
But thank you for pointing out that the hypofractionated regimen arbitrarily cuts off 50% of the concurrent chemotherapy, and that could have prognostic significance. On the flip side, the shorter course might have a different impact on lymphocyte counts, which I know we've been talking about. Would you care to comment on that angle?
So he's set me up very nicely. But it is clear that the radiation to the brain, 40% of our patients end up with CD4 counts below 200. The lower your CD4 counts, the worse your prognosis. CD4 counts, they don't come back again for 6 months or a year, which is very late for the patients. And it is clear that the number of fractions of radiation that are given might make a difference. If you take a look at the lymphopenia rates with the STOOP study and the lymphopenia rates with the PERI study, they are different. So it may be that the 15 fractions is much better than 30. Quite honestly, we don't yet know that if your lymphocyte counts are higher, that would fix the issues with survival. So I can't make a recommendation that we do that based on just lymphocytes at this point. But thanks for bringing it up.
Thank you. I have a, so with this, all the molecular markers, IDH1, ADRS, MGMT, do you now, with the final diagnosis of GBM, do you factor those in your management, like shorter course, adding temozolomide, and also maybe we're talking about tumor treatment field in your upfront management?
So the question has to do with how much do all the markers impact our standard therapy, and the answer is not very much. I think the one that is most important right now for the glioblastomas is the MGMT. If we have a patient who gets into trouble with their blood counts and they're with temozolomide and their MGMT unmethylated, we basically will sort of say that's probably the end of the temozolomide. I think the other talks that are going to come up will bring up some of the issues with the other markers, and so we'll leave that to the other speakers.
Any last questions about this case? Okay.
So, can I ask Skip to address one thing? So Skip, one of the other things that was raised was the tumor treating field, elephant in the room. Your perspective on that and elderly GBM?
I personally think that just like temozolomide is not an age-related factor and radiation is not really an age-related factor, I wouldn't set any boundaries on what I would do with the treating fields as well. I'd treat them the same.
Thank you very much.
All right. Dr. Mehta is going to speak to you about low-grade glioma, high risk, high-ish.
They say never follow Skip because you can never do as good a job as him. And so the charge that I was given was to present something that would potentially be controversial, where there could be a decision that goes one way or the other. And so instead of just giving you a high risk, I sort of decided to give you a high-ish risk, if that's even a word. So, let's see. Oh, I guess I'm using the wrong. Okay. So this is a 47-year-old female. Please pay attention to the age, just past the cutoff point of 40, who's very, very functional and presents with a single seizure episode. It's a complex partial with generalization. And instead of telling you what the MRI shows, I'm just going to show it to you. This is the pre-op MRI scan. And as you can see, there's an extensive abnormality on the flare sequence, primarily affecting the frontal lobe on the right, but extending up to and potentially through the corpus callosum and posteriorly in the periventricular and supraventricular region, and inferiorly, which I don't show you the slices, all the way into the olfactory groove. This patient undergoes surgical resection, as you would expect, and this is the postoperative MRI scan. The postoperative MRI scan shows a near total resection with some areas of flare abnormality left behind. I'm going to show you what the report shows. So this is the pathology in the report on this patient. WHO grade 2 oligodendroglioma with the following molecular features: IDH1 mutated, 1p19q co-deleted, MGMT methylated, TERT not evaluated, significant resection and resolution of midline shift with minimal residual non-enhancing flare abnormalities. Yes, indeed, there is some flare abnormality. It's read out as minimal residual. Patient was told by the surgeon, I got it all. So, what should we do? Supraradical resection, choice number one. Go back in and resect what's left. If you're in France and Dr. Dufour was taking care of you, this would be an option. How many would recommend that? None, I guess, okay. Surveillance with salvage. Patient's 40-something, the surgeon got it all. It's a molecularly favorable, histologically favorable, low-grade glioma, seizures resolved, it was a one-time seizure. Surveillance with salvage. By the way, this person is a highly functioning VP in a major corporation. Real life case. Does anybody want to follow this patient carefully with MR, salvage at recurrence? No? Okay, radiotherapy alone. I guess no takers. Then we want to ask the dose question. How about chemotherapy alone? At least one person in the audience, two, okay? Since you put your hands up for chemotherapy alone, is it temozolomide or is it PCV? So if it's temozolomide, put your hands up again. Okay, if it's PCV, put your hands up again. So we have a split vote, whether it's PCV or temozolomide. So there's some controversy there. I won't go into the cycles. How about combination chemoradiotherapy? How many people would recommend that? So a significant majority. Now, of course, combination chemoradiotherapy comes in multiple different flavors. So the PCV followers, put your hands up. Who would give PCV and radiation to this patient? Just a couple of individuals. How about some combination of radiation and temozolomide? Looks like a significant majority. So it seems that people seem to be voting with their feet here to say, let's give this patient temozolomide and radiation in some combination. Okay. Well, let's look at some of the decision-making data sets that we can potentially use to try and answer this question. So I put in 4 of the randomized trials. 2 of them are quite old, the first 2. The other 2 are relatively more recent. So let's just quickly go through these trials and see what we've learned from them. So the ERTC non-believers trial randomized patients to control versus radiation. There was no overall survival benefit from the addition of early radiation to the treatment regimen. If I can get the, it's the red. Oh, the red is the red.
Red's back.
Red's back. Well, as you can see, 5-year-old survival is in the high 60s, between 65 to 70%, no significant difference. 5-year progression-free survival, however, favored early radiotherapy with an absolute difference of 20%, 35 versus 55%. Median survival, thank you. Median survival also favored early radiotherapy. And intriguingly, the likelihood of remaining free of seizures at 1 year was significantly more favorable for the patients that received upfront radiotherapy. So these results suggest that it doesn't really matter when you do the radiation in terms of survival, but it definitely has an impact on progression-free survival and potentially on some symptom resolution, particularly in terms of seizures. Now, the second trial that was conducted in parallel was the ERTC Believers trial, because here people who were firmly convinced that everybody needed upfront radiotherapy would have a choice of 2 different dose arms. And the 2 different dose arms were 45 versus 59.4 gray, and there was no difference either in progression-free survival or in overall survival at 5 years. So then what's the right dose? So how many people want to give this patient 45 gray? So a couple of people. How many want to give 50 gray? A couple of people. How many want to give 54? Okay. How many want to give higher than 54? So intriguingly, the majority opinion for dose comes from data that we do not have from a randomized context. Okay. Now, let's look at some of the more modern trials. So this was ERTC 22033, which randomized patients after 1P evaluation, these were all grade 2 tumors, to 50.4 gray radiation. So remember, EORTC did this trial, 45 versus 59.4, and then in the next randomized trial, this became the standard dose. So sometimes these things happen. So 50.4 gray versus temozolomide times 12. This, by the way, is not uncommon. There are some institutions that do this. They will treat such patients with prolonged temozolomide with the hope and expectation that you'll get a dramatic response and maybe it'll shrink your radiation fields or you can delay radiation. So almost 500 patients were enrolled, roughly 240, 250 patients on each arm. The median progression-free survival was numerically superior by 7 months for radiation versus temozolomide for both the 1P intact as well as the non-intact patients. The overall survival was not reached in the radiation arm, but was 74 months in the temozolomide arm. So keep an eye on this number. 74 months, that's 6+ years with temozolomide alone, overall survival. Okay. So now, let's go to the RTOG 9802 intergroup randomized trial. This trial had 2 categories of patients. The so-called low risk, we're not going to talk about those patients because Helen's going to talk about those patients. And the so-called high-risk patients, and the definition of high risk was anybody greater than age 40, irrespective of the extent of resection, or anybody younger than 40 who had residual disease, i.e. subtotal resection or biopsy. And they were randomized to 54 gray, so I can see why everybody voted for 54 gray, or 54 gray plus 6 cycles of PCV chemotherapy. So remember, this was the randomization, PCV chemotherapy. And these are the long-term overall survival results. The median survival difference is not measured in days, weeks, or months, but is measured in years. It's almost a doubling of the median survival from 7.8 to 13.3 years, so close to 14 years. So a substantial benefit in median survival. And the 5 and 10-year survival numbers are also pretty impressive, a 20% absolute benefit in survival at 10 years. Did histology make a difference? So this is by histology, astrocytoma, and of course histology made a difference. If you had pure astrocytoma, survival declined, but the difference persisted even at 10 years. Patients that received chemoradiotherapy tended to do better. Now the numbers become smaller and smaller as you do subset analysis, and these were not pre-planned subset analysis, so keep that in mind. How about IDH? So these are actually pretty intriguing data. Now, one thing I want to sort of make sure that you understand, because the curves are very, very different, is to be careful about how you interpret this in practice. The numbers of patients are very small. So be very, very cautious about using these data to make absolute conclusions. In the IDH mutated patients, there's a dramatic benefit from radiation and PCV, no question about it. These patients do significantly better. In the IDH wild type, there is statistically no difference between these survival curves, but the patient numbers, there are only 20-odd patients in each arm. So it's really, really difficult to make very robust conclusions, but the pattern is substantial. So now knowing this pattern, do you use IDH to make a judgment call or not? That'll be a fun discussion that we can have. But let's go and ask one more question. Should it be temozolomide or PCV? Okay, because apparently the majority picked temozolomide, and of course the study used PCV. So I call that the Coke versus Pepsi. Okay, so RTOG 0424 was actually designed in an indirect manner to try and get to an answer to this. It's not a randomized trial, so be very cautious about this as well. The regimen here was daily temozolomide and radiation 54 gray, followed by maintenance temozolomide for 12 cycles. And the pre-specified trial hypothesis was a comparison using the Pignati prognostic factors to the EORTC survival curves with the expectation that if 43% increase in median survival was observed from the historic control, in other words, from about 41 months to about 58 months, which would also translate to a 20% improvement in 3-year survival from 54 to 65%, then the trial would be deemed positive to go to a randomized phase. So let's look at what happened with this trial. So these are 2 subgroups of patients within this trial divided by the number of risk factors, prognostic risk factors, whether they're 3, 4, or 5 risk factors. And the curves are basically superimposed, the 3, 4, and 5, so you can look at this as a single curve. So remember, the first portion of the hypothesis was a 43% increase in median survival from 41 to, say, 58 months. And if you look at the median survival line, at 60 months, none of the two subgroups have hit it. So the trial passed that pre-specified rule. The second pre-specified rule was a 20% increase in 3-year survival from 54 to 65%. If you look at the 65% line, it crosses the 3-year time point quite easily. So the trial passes on both of those counts. So if you believe in mathematical solutions to the absence of randomized data, then temozolomide passes. And temozolomide should be used in place of PCV. But truly, this cannot substitute for real data. So we do not have real data comparing temozolomide and PCV. That's an ongoing and open question. So let's get back to our patient. So we have a young patient, 40-something years old. You saw the scans. There is some residual disease. The patient believes it's a gross total resection. Should this patient go to a supraradical resection? No. Okay, there would be some challenges to that from certain European centers that believe that supraradical resection alone is sufficient, and it actually then requires no follow-up radiation or temozolomide. It's an emerging controversy, but emerging quite dramatically. How about radiation therapy alone? I guess no takers. Well, how about temozolomide alone? This is actually done in a number of centers. I'm sure some of you have seen patients with this kind of a setup that get temozolomide for a period of time, and then you see them in your practice. How many have seen that? Temozolomide alone, okay. So would you not do that? If you believe the ERTC data, remember, for all comers, the median survival was about 6 years. The median survival with radiation and PCV was close to 14 years. Now, obviously, they're not comparable groups of patients, so you can't really take the data across the board. There was a very intriguing presentation from UCSF, from Suzanne Chang and her group at ASCO 2 years ago, where they evaluated their in-house database of patients treated with upfront temozolomide and then salvage therapies down the road at progression. And the median survival was below 10 years. It was closer to 8-point-something years. So again, that practice does not seem to reach the threshold of 13 to 14 years. So yes, indeed, that's a practice out there, but the data supporting it are quite weak. So radiation plus chemotherapy, how many want to do that? The majority, again, not surprisingly. The question again, is it temozolomide or PCV? So how many for PCV? A larger number of people now. How many for temozolomide? Still the majority. So it's intriguing that we're picking 54 gray, which does not come from a randomized trial, and we're picking temozolomide, which does not come from a randomized trial. But we are using randomized trials to rationalize our decision making. I think that's a great setup to open it up for questions. Actually, let me ask Skip, what would you do, Skip?
So I can tell you what we do. Thank you. So I can tell you what we do. We routine.
Is it on?
Can you hear me okay? Okay. So we often follow these patients until there is evidence of progression with close follow-up. And then when we decide to treat them, we will usually give them radiation with PCV, followed by PCV, and use temozolomide as our backup treatment. And the rationale for that is that I've got 20-year follow-up data with PCV. I don't have 20-year follow-up data with temozolomide. And as you pointed out, we're not talking about days or weeks or months. We're talking about 7 years worth of survival. So we have some patients who refuse PCV. We obviously give them temozolomide, but our preference would be PCV.
Helen?
I would agree with Skip, but it's really individualized because once the patients hear about the benefits and risks, some of them don't want to try PCV. And actually, it's a multidisciplinary decision. I work with probably closely with a dozen neuro-oncologists, and it really depends on who their neuro-oncologist is. About half of them strongly believe in temozolomide, and the other half is PCV, so I conform because we don't have better data.
So I'm going to pick up on something you just mentioned. So as a practicing radiation oncologist, I think that's a huge pearl of wisdom. So I'm going to state it again in a more direct way, as I'm known to do always. So when you work with your colleagues who are going to give chemotherapy, first ask yourself, is this person a neuro-oncologist or are they a medical oncologist? And let me tell you why it's worth asking that question. because the neuro-oncologist can manage temozolomide very well. But when that patient gets serious toxicities from PCV chemotherapy, that is really in the domain of a medical oncologist. So it's actually worth asking that question first. And then the second question that's worth asking is, how old is the treating physician? Because if they are young, they have very little experience with inpatient chemotherapy toxicity. So factor that in for your patient. Okay. Steph, what would you do?
So actually, I think I have a similar experience as Dr. Shi. It goes a lot to who the treating medical oncologist is. And they're, it's typically a very inclusive discussion with the patient. And most patients, I will tell you, tend to lean towards the temozolomide. Although I think from other talks, people have made the point that, I think a physician can really steer a patient a good portion of the time, one direction or another, so it probably is really more reflective of the prescribing physician.
Larry.
Thanks, and I think I'm going to use this because I've been dying to use this instead of the real microphone. But sorry, I was distracted by your story about the radical resection because when Dr. Defoe came to visit and described it, he basically said you could never do this in an American hospital, that it was really resection until you hit functioning brain. And he described operating a person whose quality of life was working as a concert pianist. And so had a full keyboard brought into the operating room and spent hours having the guy play different pieces of music during the wake craniotomy to be sure he wouldn't injure him. So I don't think any of us really have experience what that might lead to. But I was going to bring up some of the points Skip did, because I pretty much always offer people observation. My view is that this has been there for a long part of their life until one day the oligodendroglioma happens to be discovered. Could have been this year, the next year, the last year. And when there's been a good removal, I always think, what does the person really have to lose by waiting to see what the growth rate is? So I always discuss that with everyone and even encourage them to consider it so that they could spend a few months thinking about whether they go ahead. But do you generally discuss this with people or really feel that because of the benefit of radiation at PCV, you should always give it at the first opportunity?
So I tend to be in a more aggressive camp of giving the chemoradiotherapy up front, and I'll tell you why I do that. I sometimes view this question using the following logic. Let's assume that radiotherapy does nothing for these patients. So it's like observation. It does nothing for these patients. We have a randomized trial of nothing, radiation alone, or nothing plus something, radiation plus PCV. And the median survival difference is about 7 years. So now, do I want to rediscover that by replacing the nothing of radiotherapy with the nothing of nothing? And I don't want to take that risk, so I don't do that. The second reason why I don't follow that paradigm is this now implies that we are going to treat at progression. The problem with these patients is that they progress slowly. They progress over a period of time. The average American relocates every 4 years. These people are bound to get lost in the follow-up system. They're bound to change insurance status. They're bound to not be able to get an MRI at some point in time. And eventually, when they're picked up with relapse, it's usually substantially larger from a volume perspective. And the use of large field radiation at that point, in my opinion, is more detrimental than the smallest radiation field that you can get in, which is immediately after the original surgery. So I don't mind waiting a handful of months, but I have an inherent bias against waiting multiple years.
That's interesting. I'm sad to say I started so long ago. It was several recessions ago. But when I first started at Johns Hopkins, many of my patients would say just what you said. I don't know if I'm going to have insurance years from now, so I am going to get my treatment now because I don't know if I'll be able to get those MRIs. Fortunately, that seems to have gone away, at least for now, but we'll see what the future holds. But thanks for that explanation.
Great, thanks.
So why don't we use this?
Hey, can I say one thing in the mic? On behalf of Jason and I don't know if for many of you know, Lawrence was the annual meeting chair last year and put on a fantastic meeting. So if you guys are having a good time at this one, it's because Jason and I were working really hard to try to meet the meeting that you put on last year.
Thank you.
So
Thank you.
Thank you, Manish. So let's transition now to Dr. Shi from Mass General, who's going to talk about another vantage point on this, kind of thinking more about the low-risk, low-grades. And I think this issue of the sort of tortoise pace of the development of these tumors becomes an issue. I've thought about it in terms of trying to do research comparing these drugs. It takes a long time to get results, but it's sad that actually an insurance perspective affects how we think about this. So, Dr. Shi.
Great. Thank you so much for the opportunity to speak to you today. And Dr. Kleinberg's points will come up in this presentation too. And Dr. Maida and I did not confer, but we actually have very similar cases, which makes this interesting. So we're on the lower end risk, sort of low-grade gliomas. We're going to start with our case, define the subpopulation we're talking about, and then review the roles, what data we have on surgery, radiation, chemotherapy, and return to the case in a longitudinal sense of telling you what happened. So our case is a 40-year-old accountant who had symptoms of vague episodic lightheadedness and sense of tunnel vision. Didn't really disrupt his day-to-day activities, so he just made do with it. After approximately a year of the system, he saw his primary care physician, who thought maybe he had hypotension, but that didn't turn out to be the case. He saw maybe he has migraines, atypical migraines, and he sent him to a neurologist who got an MRI scan that you see here. So you have the T1 contrast. It's actually a little bit enhancing and a very striking T2 flare lesion, not dissimilar to the one that Manesh showed you as well. Did not extend into the corpus callosum, but a little bit more frontally confined. So it looked like a glioma. He underwent surgery, and this is surgery. It looks actually quite similar too. There's a little bit of residual T2 hyperintensity that you can see at the genu, right where it's anterior there, the medial surgical margin. Pathology was the same, actually. It was oligodendroglioma, 1p19q co-deleted. Surgery was about 10 years ago. We didn't do IDH testing at that time or MGMT testing at that time. On his postoperatively, all of his symptoms were resolved, so what next? The patient heard about his options: surveillance, radiation, chemotherapy. Chemotherapy actually wasn't standard back then, so it was really radiation and surgery that was discussed to him, so he chose surveillance. About 4 months later, his wife woke up to him having a generalized seizure. Got another scan, looked pretty much the same. So now what next? So here are your options. Similar case, but a little bit different. He's 40, so he's kind of on that cusp of true low risk, maybe, or is that artificial? Had a pretty close to gross total resection if you count or don't count that little nubbin that's left behind. How many people would watch? Radiation, one taker, and one taker for that also. Chemotherapy, unspecified what kind, or combination therapy, perhaps most. So he thought about his options, and he understood that radiation, well, he could have neurocognitive effects from that. We don't know. His optic pathway is right under there. We think it would be safe, but can't guarantee it. And actually, your pituitary gland there, and you probably have an 80% chance of having one or more axes of hypopituitarism that would need to be replaced. He didn't like the sound of radiation. Chemo has its own set of acute toxicities too, so he decided on surveillance. He's put on seizure medication, no further seizure activity. 3 years go by, and he gets this scan, and what do we see? There's a little bit more pronounced T2 hyperintensity that you see there. Compare that back to the scan from 2 years, 8 months ago. It's little progression, but it's real. So what next? He went for surgery, second surgery now, 3 years after the first one, and this is his postoperative imaging. Pretty good resection, but you could say, there's a faint little T2 hyperintensity. Now what next? Here's more images from that same postoperative MRI scan. So you can see there's a little bit in that top panel, little brightness along the gyrus rectal margin behind the orbit. So it's not really true gross total by FLAIR imaging. He heard about his options, decided on surveillance. A year goes. Same histology, sorry, thank you. Yep, same histology, grade 2 oligo, co-deleted. A year later, this is what we see. And so he's counseled, do you really want to just wait? And he's like, my performance status, I have a KPS of 100. I have 0 symptoms. Those preoperative symptoms are gone. My life is great. Every intervention you're throwing at me sounds horrible. So what next? He waited another year. Now it's a little bit bigger. Now what do? He says, I still feel fine. That's artificial. You're telling me my scan has something, but my life is great, and anything you do to me is going to bring me down a notch. So what next? So we're going to break for a moment on him then. So low-grade glioma. So the subset we're after here. So traditionally, we used to think of low-grade gliomas in the left panel there, so by histology, what you see under the microscope, astrocytic, oligodendroglial, mixed tumor. And you can see all the lines, whether you're grade 2 or grade 3, they tend to blend together. The only real bad actor that we know is the GBMs, which you can see in the orange survival curve to the left. Now, as you go to molecular classification, and gliomas have been formally reclassified by WHO in 2016, we incorporate IDH mutation, I1P19Q co-deletion, you can see. So the co-deleted are going to be a subset of the IDH mutants, and those are the purple lavender ones, the rightmost curve. Not a great curve, right? So it still goes down pretty, it's still a downward curve, but it's the best of the ones you see there. Then there's the IDH mutants that are not co-deleted. These are usually the astrocytic histologies, and then the IDH wild types, and then GBM is still the worst acting. So we're really going for the lowest grade. This guy, he was presumptively IDH mutant, co-deleted, had a good surgery, favorable by age, we think. So what are these other factors that are considered the differentiating high versus low risk? And it's actually not clear how many of these factors are truly the factor that's important versus a surrogate to correlate with either molecular or other characteristics of the tumor or patient. So age, usually at a cutoff of 40. Older than 40 we think is less favorable. People with persistent symptoms, seizure, cognitive effects, and so forth. Or new symptom after asymptomatic period, so signifying recurrence or progression of disease. Tumor characteristics, so unresectable tumor, it's a little bit intuitive, I guess. Large tumors, loosely defined as greater than 6 centimeters, having a high mitotic index, crossing midline. Crossing midline, of course, is going to go along with unresectable and probably larger tumors, so they're all tied together. And then the molecular factors that we mentioned, IDH status, 1P19Q, and then actually MGMT as well. So probably the best data on low-risk, low-grade glioma is this. So this is that arm that Dr. Mata referred to from the RTOG 9802. The low risk defined in the red box are people that were less than 40 and had a gross total resection as determined by the surgeon. They had great performance status, neurological function. And there's 111 patient, and progression-free survival at 5 years is actually only 48%. It's roughly half. That's actually not that great if you think these are supposed to be the most favorable patients. And we just heard data of higher risk patients doing much better in the same time frame, but with the intervention of radiation and chemotherapy. So if you break up the data, and these are 3 different ways presented, progression-free survival by histology and H&E. You see oligodendroglial histology does better, smaller tumors do better, and having less residual disease does better. So based on that, what would you do? Okay, so let's go over the roles of the interventions that we know so far. So the role of surgery for low-grade gliomas, this is the same data you saw, but just was a little bit more information on the left there also. It's not just less than 1 centimeter, it really depends on the amount of disease that's left behind. The people who had less than 1 centimeter of disease had the lowest local recurrence risk, roughly 25%. 1 to 2 centimeters jumps up 68%. More than 2 centimeters, the worst, or almost 90%. There are other similar data out there. This is from MD Anderson, looking at IDH mutant gliomas. So these are molecularly at least the more favorable half. Whether there's residual enhancing tumor or entirely non-enhancing disease, which is mostly the case, and we look at overall survival, the amount of disease that's left behind makes a big difference. You leave more than 1.5 or 2 centimeter disease left behind, that has a significant difference, negative likelihood of survival outcome. How about radiation? We saw this data in tabular form earlier, so we know that radiation early, this is no chemotherapy, just after surgery, radiation up front versus saving it till time of progression, no overall survival difference. So if that's your endpoint, then you can say, well, why bother, right? But we also heard argument for progression-free survival. Maybe you don't want that life of the tumor coming back and needing another surgery, or having further symptoms, seizures or so forth related to disease. So it really depends on what you and your patient feel is the most important endpoint. perhaps one of the most compelling data comes from this. So this actually was considered high-grade gliomas, but now we reclassify them in molecular, so they're not so high-grade anymore. This is a cooperative group study looking at anaplastic just gliomas. There were 1p19q co-deleted was the definition, so by definition, oligodendrogliomas. And this study has undergone 2 revisions or 3 types of the way that the study is looked. But this was the original design. It was radiation versus combination, the Stoop regimen versus temozolomide alone. And the early data that has been released is only 36 patients, so that's the downside. And it's early data, right? Because we really want the 14-year data, and that's not here yet. But if you look at this, the radiation versus combined therapy versus chemotherapy alone arms, the least amount of toxicity when you got radiation alone, you're most likely to finish treatment, which probably makes the patient feel better also that they got through the prescribed treatment. And by far the lowest in either combined arms of if you got radiation, the likelihood of progress was single digits at almost 3.5 years. Compared to the chemo alone arm, half of those patients progress in that time. So how can you do chemo alone, right? You got to do radiation. So compelling for radiation, but the problem is, as with the case I presented, everything is trade-offs. So there's trade-off to radiation. We know subjectively from treating patients, I think most people who take care of these patients, you see there are symptoms, but it's really hard to quantify, I think, neurologic symptoms sometimes. There are a few studies, such as this one, cross-sectional study of 195 low-grade gliomas, roughly half of them received chemotherapy, and just compared them to non-brain tumor patients. These are hematologic patients that either had non-Hodgkin's or CLL, who had nothing specific localized to the head, did not get any radiation, but did get chemo, and then 100 healthy controls. And what they found was the low-grade glioma patients had a worse cognitive functions to the hematologic patients who had a worse cognitive functions to the healthy patients. Not so surprising. There are specific domains within cognitions that definitely seem to be affected. Specifically memory, attention, executive functions. They also found that those patients who receive radiation, who receive more than 2 gray per fraction, appeared to be impaired the most with regards to memory, suggesting that maybe radiation more than a tumor was the source of impairment, but hard to say because it's really, they go together. It's the people who are getting radiation to the head or the ones with the tumor in the heads who are doing worse. The same investigators went back on a mean of 12 years later, found 65 low-grade glioma patients from that study who had not progressed, invited them to participate in this second study. Half of them also had radiation, and what they found was here on the right. So these are the mean Z-score of the neurocognitive functions. The different domains are listed in the 6 graphs there. And the red line are the patients who did not get radiation, and the green line are the ones who did get radiation. So generally speaking, the folks with the green line, the radiation, were scoring a little bit less in all of these domains and also tended to go down a little bit with time, mean of 12 years later. Quality of life data have also demonstrated when we look at, these are established batteries, overall quality of life, cognitive function, anxiety, and depression, that overall, over the first at least 3 years of follow-up with these patients, their quality of life does go down. So when you're talking to a patient in front of you, and this, how much can they bank on investing in the future of 7 years and 10 years from now versus the next 3 years, this is a big deal to them. And actually, it was also noted hair loss improved. All but hair loss improved with time. Hair loss, something we fix now with intentionally modulated and VMAT treatment. And those folks who are actually on anti-epileptic therapies tended to do worse, which is something for us to keep in mind as well. So then this has been part of the reason or interest in proton therapy for low-grade gliomas. And as proton centers have increased in number across the country, I think this becomes a more compelling question. This is a pilot study that we did with 20 patients, just a single arm, treating them with protons and following them prospectively at time of when the team decided radiation was indicated. 12 of the 20 were treated at time of recurrence. Nothing unusual was found, all well tolerated, no decrement in neurocognitive function in the 4 and actually 5 years of follow-up, and stable emotional well-being and quality of life based on questionnaires. And so the doses are the same to the target, in this case, the left frontotemporal lesion. It's really that low dose bath to the rest of the brain that we're wondering, what other impact does that have? And I think really the study that's going to answer that question is open right now. You don't have to be a proton center to be participating in a study. This is NRG BN005 that's randomizing IDH mutant, so these are the lower grade glioma patients between protons and photons, the same 54 gray that we have no randomized data to support, but we do it. It's good intermediate, right? And the cognitive function is the primary endpoint. So if you're a proton center, you can obviously randomize to both arm. If you're a photon-only center, you can affiliate and keep the patients if they randomize to photons and then send them to your affiliate proton facility otherwise if not. So the faster you accrue, the faster you have data, right? So, okay, how about chemotherapy? You've already seen variations of this data. This is from the 9802. This was technically the intermediate risk low-grade glioma patients, but of course this study was designed and launched in 1998 when we were just based off histology, and now we know a subset of them, the IDH mutants, and even more specifically, the oligodendrogliomas are going to be the ones that are co-deleted that actually are quite favorable, and you can see these are the progression-free survival curves, but similar in significance with regards to overall survival, that adding on PCV to radiation improves both progression-free and overall survival in these patients. This is just to say, you don't have to read the details, that there's trade-offs to everything. So the trade-offs of PCV, the first 5 columns of numbers is radiation alone, the right 5 columns is with PCV, and there's a lot of zeros and ones with radiation, and there's a bunch of double digits with PCV. So it's not a free lunch. So if we bring the data together that we have, what I think is some of the best data to help this individual decide what to do, again, there's low risk, supposed low risk surveillance, low-grade glioma from 9802, surveillance alone. Overall, the progression-free survival in that cohort was 48%. There's the intermediate risk data that came out recently that randomized people between radiation and radiation PCV. Overall comers, there the numbers on the bottom, radiation's 44, radiation PCV was 61. If we looked at the oligodendroglioma component only, progression-free survival at 5 years was closer to around 75 to 80%. And then if you look to high-risk group that we heard about, the R2G 0424, single arm, but these are supposed to be high risk, they have 3 or more unfavorable features. They're given 54 gray with temozolomide, yet they have a progression-free survival equivalent to that of the super low risk, who are supposed to do really well. So what do? We're back to our guy. He's 5 years out from his original diagnosis. He's had 2 surgeries. He's 2 years from his last surgery. He has this growing nodule, and we're asking him what to do next, and he is not liking radiation. So he went for temozolomide. He did a year of temozolomide. This is a scan after a year. Doesn't look better. So we're telling him we don't like the way it looks, and he said, I still feel just fine. So he waited another year, and it got a little bit bigger, and his medical oncologist is feeling very uncomfortable about this, and he still wanted to hold out. So about 9 months later, it's looking even more ugly. She sends him to us and basically says, get a second opinion. And so what do you think we did at this time? We took him, we convinced him, we sent him to surgery. Who knows if this is the right answer, right? If you're back to quality of life, each one of these interventions, his performance status was perfect. He allowed us to take him to surgery a 3rd time, thankfully came out scratch-free. So now he is 2 years from temozolomide, 5 years from a second surgery, 8 years from his first surgery. He has no symptoms, and it's the same pathology, oligodendroglioma, co-deleted. Now what next? And so if you factor in some of the points that have been mentioned in terms of quality of life, he has no regrets, by the way. He goes, I am 3 years later, I am 3 surgeries later, it's 8 years from this diagnosis. I've made 0 wrong decisions. I do not regret getting radiation because he told me I had 80% to higher chance of having pituitary dysfunction. I don't have that. But now he's not the same. He's not 40 anymore. He's 48. So is that high risk age? How do you factor someone who's recurrent 3 times? And is recurrent 3 times arbitrary because we just decide when to do surgery? He held out for a few years before having that 3rd surgery. He could have been recurrent 4 times if we went every year, every time there was like a half a centimeter growth. So surveillance is actually not unrealistic in his mindset. Anyone want to do surveillance? Or radiation only? Or chemo only? Or combined radiation with temozolomide, a few takers, and radiation with PCV, which is what we told him because we're data-driven. So he is getting he's about to get radiation. He's coming for radiation, protons, and then he'll get his PCV. So in summary, I would say there really is no one standard of care, and this is a common theme that you've just heard from the prior speakers. Most opinions and decisions are extrapolated from studies. Studies are fraught because they take 10 or more years to mature, and then what do you do in the meantime? Better surgery seems to be associated with better outcomes, but we don't really know, is that because of the disease or the surgery? Radiation improves outcome, progression-free and overall survival, so does chemo. My personal bias, I think most patients with low-grade gliomas should receive radiation and chemo. The specifics of dose, timing, when, I think are all to be individualized, and there's not necessarily one right answer for each patient. Thank you.
Any questions?
I have a question.
Yep.
So I'm going to ask each of the panelists. By the way, fantastic panel, fantastic panel. What would each of you do if it was you?
For this last case,
For this last case, what would you do if it was you?
if it was at this last juncture, I probably would do the radiation and PCV. Partly, and it's bits and pieces of everything you heard. The quality of life component, I think, is really important, but I agree with Dr. Meda's point that, like, there's only so much more surgery this guy can do if this tumor comes back, and your field actually does get a little bit bigger each time we wait for it. And there's a balance. If it's growing really slowly and it's still small and a little bit bigger, then that's not such a big deal. But once you start jumping other territories in the brain, we're going to run into more deficits. I would definitely intervene at this point. Not saying that's necessarily the right thing, but that would be my bias.
Yeah, interesting. Go ahead.
So I would agree with Helen. I mean, after a while, surgery gets tiring, and many of these patients who don't want to be treated earlier make a decision, and they're willing to live with the side effects, even though they weren't willing up front. And what he did was the way he wanted to do it, and it will play out the way he wants it to play out. So I'm good with that.
I have a question, Dr. Shi. The question I have is, in a patient with a lower grade glioma, you know, we know it's not nearly as infiltrative as the high grade gliomas that we treat. And so I wonder about techniques, since much of the patient's decision making would be concerned about things like memory or perhaps hypopituitary function. Those things, you know, conceivably looking at the images could be avoided with very highly conformal fractionated stereotactic, for example, things like that. What do you think is the role, or how should we be looking in the future at treating these patients from a technical perspective?
Okay, so let me take a stab at that, but I'll do that in continuation to the answer to the first question. What would I have done at this point in this patient if it were me? I would have gone with radiation and PCV for a very simple reason, because my thought process is my thought process. And my thought process is to look at all the options and say, why would I not do A, B, C, or D? So why would I not do radiation? And the reason I would not do radiation is because of the concern about cognitive deficits, which is the question that you're getting at here. So we saw some very elegant data domain-wise using neurocognitive testing. The question I would ask Helen is, did you do domain-wise neurocognitive testing on this patient?
No, we
Because
did
I
not.
bet you'll find the same deficits in that patient. And the reason I say that is because radiotherapy suffers from what I call the speed trap phenomenon. Should we use our societal resources to put our policemen to detect individuals that speed at 31 miles an hour in a 30-mile zone and punish all of them and give them tickets? Or should we really be focused on looking at people that are driving at 50 miles an hour in a 30-mile-per-hour zone? I think the answer is obvious. So what we really need to be looking for with these cognitive deficits is large decrements in cognitive deficits, not subtle changes because you have a micrometer that can measure a tiny little change in a domain of cognitive testing. To use that for clinical decision making is illogical to me personally. Now, it may be logical to somebody else, but not to me. So that sort of segues into the question that you asked, which is, should the location of the tumor and the possible impact on cognitively rich domains or locations of the brain play into technique selection? Up until now, the answer to that question would have been sort of an intuitive yes. Now we have a randomized yes to that question. And that randomized yes comes from a clinical trial published from India by Jalali et al., where they used two different techniques in individuals with slow-growing intracranial neoplasms. They were randomized to a technique that treated a larger volume of the brain, versus a technique that treated a smaller volume of the brain. They used the technical resources that they had in their capacity, 2D versus 3D, 2D versus 3D plus IMRT. But the principle was lowering the volume of excess brain that was getting unnecessary radiation. And in this population of young patients, pediatric and young adults with slow natural history tumors, there is a dramatic benefit in essentially every domain, including endocrine and cognitive and quality of life, in favor of lowering the low-dose volume of the brain that's exposed. So therefore, the answer is obvious. We now have randomized data. Use the technique that produces the least low-dose bath that you can get.
So I just had two questions in regards to cognitive function. In the interest of preserving cognitive function, there's some data for patients getting whole brain that the use of memantine may preserve cognitive function. So would that be something that's reasonable to use in patients with low-grade or high-grade glioma getting large high-dose radiation to the brain? That's one question. Second question would be in regards to radiation volumes, like you mentioned, Dr. Mehta, specifically with GBMs, right? Like historically, we'd put 2 cm to the flare and 2 cm to the post-contrast. Some may think that's too large of an expansion. What expansions would you recommend on your GBM patients?
Do you want to take the first one?
Memantine, I find memantine is pretty well tolerated in most individuals, and if it's not, I feel like it's low risk to stop. To me, it's a medication that either helps or it does nothing. It's not absolutely clear that it helps, but the data suggests if it does a little bit for some people, maybe it's placebo effect, because it's relatively a benign medication in patients who are motivated and looking for something. I use it, and I don't really discriminate between whether it's brain metastasis, low or high-grade glioma, it's any cranial radiation.
We actually did a study with armodafinil and had some good results, and I think same thing. It's typically well tolerated. It's got a very doesn't increase the risk of seizures, so you can always try that. Headache, a little jitteriness are the side effects that we worry about.
So I was an author on the memantine paper, and maybe I'll throw cold water on it. It's not a home run by any stretch of the imagination. At best, it's a single. So yeah, you get a modest level of protection. But honestly, that trial was done to see, could we really modify radiation? And the answer is yes, we can. But memantine is not the home run. It's just the first step. And yeah, if you've got nothing better to do and there's a high-risk patient, I'm okay using it. I'm not enthusiastic about using it because actually it does have side effects. The thing that I do use more often is a deliberate attempt at hippocampal avoidance whenever I can in my treatment design. Because again, in the absence of randomized data, except for the Jalali paper, I really believe that that has a greater impact on cognitive sparing. You segued that into glioblastoma. Should we be decreasing margins to achieve that? Let's take that offline because that's a 1-hour answer. Okay.
Thank you very much.
And with that, I just want to thank, again, the speakers and the moderator for a fantastic session.